So we have the opportunity to discuss a clinical case with the whole faculty of the ESOU online module. So thank you, Benjamin Pradere, who is from France, currently working in Austria, to present this clinical case. And we will discuss it with Virginia Hernandez from Madrid, Spain, and Sharok Shariat from Vienna. And we will discuss together with all the questions you are going to raise through this very interesting clinical situation. We are listening to you.
Thank you very much, Professor Rupre, and thank you to all, the whole faculty of the ESU. I'm very pleased to present you today this clinical cases where we're going to discuss the position of immune checkpoint inhibitors in the perioperative settings for patients with muscle-invasive bladder cancer. So the cases that I propose to do today is a 67-year-old patient, male with gross hematuria, retired plumber, who is a past smoker and had high blood pressure, hypercholesterolemia, and diabetes. His BMI is 25, and he has a limit renal function with a clearance around 61 milliliter per minute. So we diagnose a tumor on the posterior wall of the bladder on the ultrasound. Luckily, we had the opportunity to perform a multiparametric MRI with a VRADS evaluation of 4. We performed an abdominal and a chest CT scan, which did not find any distant metastasis. First TURB was performed, finding a pure urothelial carcinoma, and the pathologist answered that it was at least a PT2 urothelial carcinoma. So what we're going to do during these clinical cases is to discuss what are the most important and different settings, what we can offer to these patients. So for you, according to the topic of this clinical cases, would you propose to this patient, 67-year-old patient, a neoadjuvant CPI or not?
Virginia, what is your position?
Okay, that's a patient that could be fit for cisplatin chemotherapy. So his renal function is okay and performance status is okay. But if you have the option of a clinical trial, then it's always a good option.
Well, would you say yes or no here?
I would say yes.
Okay. Okay, fine. And Sharok?
It's a good question. Look, we are at academic centers. We always try to get the patients into clinical trials. So I would say yes too. But I'm still have to make you have to still discuss with the patient one important thing. You have here a standard therapy with a neoadjuvant cisplatin-based combination chemotherapy, which has a survival advantage. And we do not have such solid data from the Pure One or the Abacus. So we have to inform the patient that we may have a downstaging that is interesting, maybe less side effects or adverse events than the chemotherapy, but we do not know if this will translate in any survival advantage, but that's it. And the question is also your CPI trial, whether it's going to be a combination therapy, it's going to be with chemotherapy, or it's going to be single IO, and that needs to be discussed, because if you're going to do combination therapy with another IO or chemotherapy, you certainly have to inform the patient that your expected less adverse events of a single IO will go away probably with this combination therapy or combination with another IO.
Yeah, I fully agree with you, Sharok, and we're going to discuss this and talk about that. So yes, I think it could be a great option to propose the CPI. We have already shown that it could be offered to a more wider eligible population, and we're gonna discuss how to propose this neoadjuvant CPI. So my question to the expert now is, would you propose to enroll this patient, in a trial with CPI as a single agent or a combination therapy with combination CPI, IO, or chemotherapy?
Okay, for me, this patient could be fit for a single agent, maybe in a more locally advanced disease or M positive, I would go for combination therapy.
Sharok?
Well, I have to tell you, we have two preliminary data of two studies that have been reported at with small size at meetings. So I certainly will feel very uncomfortable to have a combination therapy now and to to discuss that with a patient in any shared decision making where I can be confident of the information I'm giving to them. With a single agent, you have a little bit more mature data, the single arm studies. So I really don't think they're mature yet. In a clinical trial, I would agree with Victoria. Virginia, sorry. I would be certainly comfortable in a single agent setting to not forego the cost benefit, ratio, to not lose that. In a combination therapy, I like to push them. This patient has a very large tumor. He's at least at T3. Would be very likely to have macrometastatic disease.
Yeah, I fully agree, but still, I think there are a place for this patient for combination therapy in a trial, even if the first report from the metastatic urothelial carcinoma IO combination during the last Congress showed not a lot of benefit on combination immunotherapy in first-line metastatic. So CPI in a single agent, you can propose him as in Abacus or Pure01, who are the already published data. The Abacus was a phase 2 published recently with a complete response rate of 31% and 17% in, especially in T3, T4 patient, and this patient looks like a CT3 tumor, and found some markers as CD8 plus in the tumor who can benefit more to the atezolizumab. It was interesting because in the Abacus, TMB and PDL1 were not predictor of any response, compared to the metastatic settings where PDL1 positive and TMB plus were more willing to answer to the response to the therapy. And the Pure01 is the other study, as you mentioned, for single agents with pembrolizumab and a complete response rate of 37%. And in these settings with pembrolizumab, there were a trend for an improvement in patients who were PDL1 positive with a CPS over 10%. We also have the combination therapy. Actually, most of the studies proposed are still enrolling patients. We have the BLAST study who have been shown and presented at the ASCO 2020 this year with a complete response rate of 49%, which is quite impressive and a bit higher than the single agent IO. And for the pembrolizumab associated with gemcitabine or gemcitabine plus cisplatin, again, we had a complete response rate of 45%, which is a bit higher than the complete response rate for single agents. The other combination are still in process. The last one has been published in October 2020, and it's the Nabucco study. It's still a small study with a very small cohort, where the first and primary endpoint was the possibility to resect the tumor 12 weeks after Nivo EP in cis-ineligible patients. In these settings, the complete response rate was similar, with approximately 46% of the patients who had a complete response rate, and the downstaging is 58%. The interesting thing is that, in contrast to the study with single agents as Abacus or Pure01, where it's a monotherapy, the association of ipilimumab and nivolumab showed an independent answer, whatever was the T effector signatures or CD8 plus in the tumor. So finally, would you propose this patient have a neoadjuvant, maybe a therapy, but maybe you can also propose a perioperative therapy with CPI? Would you propose that or not?
Virginia?
I think at this stage, no. I would go only for neoadjuvant and see what's the response rate.
So you would stick with the standard. And
Yeah.
Sharok?
So I don't know what you're talking about perioperative therapy, but I like to think of us taking not a straight road, but at least looking at a dynamic response. So in a patient like this, I would certainly, if I would be in a clinical setting, look at the neoadjuvant cisplatin-based combination chemotherapy. Would he have a response? I would certainly not consider a sandwich therapy with something afterwards. Would he not have the response that I would expect, you know, with a downstaging and a T0 rate or a downstaging that is significant? I would certainly consider this patient, and if has a lymph node positive disease and so on, I would certainly consider this patient for clinical trials where we could give him some adjuvant therapy. And you know, there's been the Checkmate 274 that included such patients with patients who received neoadjuvant therapy, and that has shown a survival, a progression-free survival benefit. So I think also a metastatic-free survival benefit. So I think that would be certainly theoretically an option I would consider. Short in a clinical trial, it's not been approved yet.
Yeah, I fully agree. And for now, it's still complicated to enroll patients for perioperative treatments. There is still the Energize study, and where nivolumab is associated with gemcitabine cisplatin plus linrodostat or placebo before surgery, and in adjuvant post-surgical treatments. And there is also the Keynote 8666 with the phase 3 with pembrolizumab before and after surgery. But for these patients, considering that he can benefit from a neoadjuvant chemotherapy alone, which CPI would you choose according to the data we have for now in the different studies?
That's I would say maybe Tes or Pembro.
I hate to answer this question because you're trying to make a comparison across studies with very different cohorts and quite heterogeneous response results rates. Now, I could make some inferences from the metastatic setting, which we know is suboptimal as well, where we know the level 1 evidence for the second line is only for pembrolizumab. So by that inference, by the phase 3 randomized trial, taking that concept and with the quite mature data that the Pure01 has shown with adequate, you know, everybody goes to surgery, everybody receives it. The complications do not seem to be more. This is not a controlled trial, the Pure01. I would feel very comfortable with the pembrolizumab in a neoadjuvant setting. Not saying that Atezo will be inferior, but just, you know, trying to make some arguments in one direction or the other one. But I think the point you made early on is a very important one. This patient is young, and this patient seems to have quite an aggressive disease. It's pure urothelial carcinoma, but it's at minimum clinical T3. He's going to have macrometastatic disease. I would like to know, does he have lymphovascular invasion and so on? Because I think he may need more than a single agent IO probably. But this is just a thought that I'm playing and discuss with the patient.
I think one point we could emphasize also to help us to if we consider that all these drugs would be approved, which is not the case yet, would help us to make a choice, regardless of a direct comparison, would be the fact that the PDL1 stratification, for instance, would help us to answer. We didn't address the point of the variant histology in that setting, and we all know that it is a factor of bad response in chemotherapy. So there are many, I would say, critical small issues that we need to dig into before we can make a choice of a drug among another one in a tumor board, because so far with what we know would say any EO available would be happy with, and I think the comparison between the survival curve appears to be difficult.
I fully agree with you, and I think that so we can propose him to be enrolled in a trial in a neoadjuvant settings, and considering that he had a CPI alone with a radiological regression, you asked me to discuss about the surgery. And for now, the surgery in CPI patients as him, he underwent a radical cystectomy after pembrolizumab. And we found that this kind of surgery is fine. Andrea Necchi and Alberto Briganti published early this year the first results of the Pure 01 patients who underwent a radical cystectomy and found no differences in terms of complication rates and readmission compared to chemotherapy. The number of complication is around 26% for major complication over Clavien 3. So there were no lots of complications compared to the normal ones. So finally, this patient, after discussion, if he doesn't accept the neoadjuvant treatment, he went for a cystectomy, and the final pathology was a pure ureter carcinoma with a downstaging of PT2, but he was N plus M0 without histological variant. Would you propose to this patient an adjuvant treatment? If yes, which one? Chemotherapy, radiotherapy, CPI, or would you just do observation?
Virginia?
I would say yes. If again, I would say chemotherapy as a standard, but we should discuss if there is the option of a clinical trial with CPI. I would try it.
Okay.
So I certainly would not do radiotherapy in this setting. If your surgical margins, soft tissue surgical margins have been negative, so it has no role, and even if it is positive, probably no role too. I would be interested to know what his lymphovascular status would be. That would certainly increase my worry, and I would like to know how many nodes were positive and how many were taken. So you know, having sort of a nodal staging concept. If you have not taken too many nodes and you have 1 or 2 nodes positive, you probably have missed some of the metastasis, and I would be more worried and pushing a little bit more towards an adjuvant therapy. So lymphovascular invasion and if you want, your lymph node density will be sort of a question that I'm looking at, and not only the density, but also the absolute numbers. At the moment, chemotherapy with cisplatin, if he's eligible, if he remains eligible, after the surgery and has not had too many complications of the surgery, I would, he was at a GFR of 60, he should stay at a GFR of 60 after surgery, would be the standard of care option. But the CPI, as I said, is checkmate 274, very promising results, would be as part of a clinical trial an option that I would highly consider.
Exactly, and for the adjuvant treatment in CPI, we have already 3 studies who are finalizing their results. The first one was the InVigor 010, and there were no benefit on the primary endpoint, who was the DFS. Recently, BMS gave some answer and said that checkmate 274 met the primary endpoint, as you said, even in PD-L1 positive patients, and we are still waiting for the ambassador study with pembrolizumab. So in an academic center, I think, yes, we should propose this patient to an adjuvant treatment with CPI, according, of course, to the more precise pathological results, especially nodes and lymphovascular involvement. But before any neoadjuvant treatment, we can say that considering that the patient finally refused the management, which includes a cystectomy. So we also discussed this topic just before, but would you propose a trimodal therapy, including CPI or chemotherapy for this patient in a trial?
I think Sharok is not a huge fan, but he will let you know again what he thinks.
So I would, this is a young man that probably you could get a neobladder. I'm not sure you could do the nerve sparing, as it looks pretty extravesical on one side. Maybe on the other side you could attempt it. So I think in that concept, a unilateral nerve sparing, for example, but at least in neobladder concept, the radical cystectomy with an extended lymphadenectomy would be my primary choice. Now, for some reason, some patients refuse it at any cost. In those patients, we do not have any other options as a trimodal therapy. His tumor is too big, his T3 So I do not feel comfortable about it. And the location of the tumor looks to me that he's probably likely to have hydronephrosis as well. So I think he would not be a good candidate for it. I would try maximally to discourage him for that. Does he want it? Then I would at least propose him an inclusion in a clinical trial where you would enhance the results with a CPI. So it would be a cisplatin based, or sorry, it would be a standard trimodal therapy where you try to resect it all. I don't know how you can do it with this tumor, but you would try to do that, and you would then give a radiation dose. You give some form of chemotherapy according to the clinical trials that have been approved so far, have been tested so far, and you would enhance it with a CPI. So give him maximal chance. If a clinical trial like this would be available and he refuses everything else, okay, so be it. Still think it's inferior.
Yeah, it's probably the best way is to convince him to get a cystectomy, especially because he's young and has a huge tumor, despite the fact that CPI have shown an interesting role in addition to radiation therapy, where especially irradiation could upregulate the expression of PD-L1 tumor and shown some abscopal effect in accordance to radiation plus CPI. Anyway, there are 2 studies where we can enroll this patient if he finally wants to have a trimodal therapy, and most of them are randomized study with atezolizumab and pembrolizumab, who are compared to placebo plus radiotherapy. So finally, as a take-home message, I think to continue to progress in terms of our understanding in the use of CPI in muscle-invasive bladder cancer in the perioperative settings, we have to continue to enroll patients, especially to understand the best setting between neoadjuvant and adjuvant therapy. As we have discussed, we are still waiting for data from both of the studies. The class of combination therapy still need to be refined, and comparing cisplatin eligible and ineligible patient, PD-L1 plus and CD8 plus, as we have seen in first-line metastatic urothelial carcinoma, it's still not really clear if the combination therapy could help, and we don't have a lot of follow-up for these patients, so we still need to wait. CPI seems to have a promising effect in the neoadjuvant settings, better than the adjuvant, according to the IMvigor010, who didn't reach the DFS, which was its primary endpoints. Anyway, the use of CPI in a neoadjuvant settings seems to not impact the surgical outcomes, and we still wait for a biomarker-driven therapy, as we already discussed, to prioritize the best management and treatment, and hopefully we will have and see some precision RCT in the future, like the bionic in renal cell carcinoma, where we'll be able to create a real precision medicine for these patients.
Thank you, Benjamin, for coming up with this case and the nice discussion we had with together with Sharok and Virginia. I think you made a very important point. If there is any future for these drugs in the field of localized or locally advanced disease, then there is room for urologists to be involved in a clinical trial. And we don't want to let the room open only for medical oncologists, because we know very well these patients, we know very well this disease, and we have to be invested as a PI or a clinical investigator, or come up with ideas of trials to do and to perform in that setting, because there is a role of the combination of these drugs with the surgery. So it's very important for the young generation to be involved in the development of these drugs in the localized setting. I would like to thank you all for your involvement in the discussion of the case, and especially Benjamin, who came up and he has some difficulties with his slides, but finally at the last minute, he came up with a very convincing clinical case. Thank you very much.